So, ladies and gentlemen, I'm going to change tack a little bit here and just propose to you something a little bit more controversial, arguing that really in terms of newly diagnosed patients who are not transplant eligible, whilst I completely concur and agree with Saga that the concept of efficacy in this population is everything, that we must be able to ensure continuity of therapy to improve outcome. As we look to the future versus looking to the past, actually, I would argue that 3 drugs for older patients will become the standard in the context of better agents that are better tolerated and more efficacious. So that's going to be essentially the platform of my proposal this morning. So to segue this, I think it's very important just to remind ourselves of advances in the understanding of biology of myeloma. Obviously, we've recognized for some time with seminal work from a number of investigators, but not least of all, my mentor and partner, Dr. Ken Anderson, that the interaction between plasma cells and the bone marrow microenvironment is absolutely essential to understanding the disease. And as you think of this, to recognize that there are multiple targets in this context, and then obviously, intellectually, it's obvious, it's a sine qua non, and we've seen it time and time again, both with first-generation and next-generation novel agents, that this interaction is key to target. And in that same context, the ability to use multiple agents to overcome resistance mechanisms is fundamental as we think conceptually about the disease. Now, in the same context, we've recognized that in the biology of this illness, the heterogeneity between patients is actually mirrored also by the clonal heterogeneity and diversity that occurs within a patient over time. So this whole construct of clonal tiding and clonal heterogeneity is important to grasp because I think it informs us as we think of clinical practice. And obviously this is actually from a paper published by Gareth Morgan a few years ago now, but I think it's a very nice demonstration of this construct. I think what has to be understood is that by the time patients achieve this point in their illness, we're running into real challenges with what we may be able to offer. And therefore, what we do here in the context of minimizing clonal advantage and trying to shut the process down as early as possible is fundamental. And this is particularly true when you think in terms of tiding, of where we see as clinicians this ebb and flow of illness that can occur. And when that flow comes, when that spring tide, in fact spring is the wrong word because it's obviously hardly a good thing in any sense of the word, when that tide of disease thrusts forward, it's extremely difficult to control. So the ability to use combinatorial strategies to shut this process down, I would argue, is essential. Now, as Saga alluded to earlier, both just now and previously, obviously we've completely changed the landscape of this illness in the last decade, and it's been truly a privilege to be part of that process. But I think what we have to recognize is that as we've developed better and newer drugs, we've now got the real opportunity to actually put together 2, 3, 4 drug combinations, one might even argue, in the appropriate setting to optimize outcome. And this is a slide I like to show. It's actually from courtesy of Brian Dury, because it emphasizes the critical point that what you use early in the disease really matters. Because ultimately, when relapsed and relapse refractory disease occurs, our options, whether we, of course, recognize the hope of the newer agents notwithstanding, our options actually are diminished. And in that context, what we do here really matters. So in other words, therapeutic parsimony up front does not make sense. And the first clue we had to this, interestingly, was in the VISTA trial, where we looked at VMP, which was 3 drugs, obviously, compared to 2, M&P, which obviously now we would consider obsolete. But nonetheless, if you looked at the group of M&P patients who crossed over to receive bortezomib-based therapy later, their outcomes were inferior. So using better drugs earlier in combination clearly has a platform. And here we have some evidence to support that. If you look at various cohort studies of outcome, if you look in the first part of the last decade, this is the survival that was presented and published by Shaji about a year ago now. And if you look now in the last 5 years or so, this is clearly improved, and it's been in the older patients. Now, obviously, that represents the impact of novel therapies. I would argue we can still do better, and again, by rational combinations of bringing in more drugs. And why does this particularly matter? Well, it particularly matters because we must remember there still is no plateau. And as I mentioned earlier, once our IMiDs and proteasome inhibitors fail us, once they fail our patients, we do very poorly. So it really matters what you do early and how you do it and how you can achieve continuity of therapy in that context. Another very important point that clearly applies to the older patients as much as it does to younger is this construct of early deaths and high-risk disease, which we fully recognize and remains a major challenge. And as I said, no plateau. So when we think of algorithmic approaches to frontline therapy, I would argue that these are becoming increasingly difficult to support. I completely agree with Saga that this definition between 65 and not really is truly arbitrary, and I have exactly the same practice pattern as he does, in that I will reserve transplant in younger patients who clearly may not be best served by it, but at the same time certainly don't have a cutoff of 65 for older patients. This algorithmic approach is reasonable as a sort of starting point, I would suggest now, or perhaps before or previously. Going forward, I think these increasingly blur. And my argument here would be on that platform that rational combinations apply just as much to the younger and older patients in the same continuity and spectrum of care. So let's think about how we might rationally think about multiple agents in older patients, and again, recognizing fully what Saga alluded to about tolerability. We have seen clear progress, and I don't want to repeat this too much simply because Saga covered it previously, but I think you can see a clear trend in favor of multiple agents, and I want to bring your attention particularly to Antonio's pivotal work using the combination of 4 drugs here, VMPT followed by VT. Now, I would fully first to acknowledge that there were side effect profiles here that were challenging, but the point is that we have newer agents and better ways of giving existing agents that make the principles of these combinations and continuous therapy apply, but the tolerability arguably to be much better. And when we look at this in comparison, this is again straight from Antonio's work subsequently published, not only do you see obviously the improvements in response rate, but very importantly, you see improvements in clinical benefit, and in fact updated versions of this with 5-year survival show actual survival benefit, and here they are illustrating that same point. The other key point from Antonio's work is that maintenance therapy, or the ability to continue treatment, in this case with the combination of a proteasome inhibitor and an IMiD, really matters. And when you take the pedal off the metal in terms of continuous therapy in this context, relapse occurs at a rate that's equivalent to the control group once you stop your treatment. So this is actually the fully updated data set from that, showing again this 5-year survival benefit, and also this very interesting effect of an impact on time to next treatment. In other words, that continuous therapy followed then results, I should say, in when relapse does occur, rather than in a resistant phenotype emerging, a phenotype that in fact allows you to delay time to next therapy in the context even of biochemical relapse, which I think is a fascinating observation from this data set. But I think to Saga's point, tolerability from this platform matters. That being said, with the newer drugs that I'm going to show you in a minute, I would argue that we have the opportunity now with more tolerable agents that are going to be more appropriate in older patients to really go forward. So how do we improve with what we currently have? Just a couple of points to make here. We recognize, as Saga mentioned, obviously, that lenalidomide is the new standard. Obviously, there are refined mechanisms now to delivering bortezomib, be it weekly, as illustrated here, or subcutaneously, as pioneered by Philippe Moreau and the group from Nantes, and subsequently validated in prospective trials. And obviously, we now have the advent of carfilzomib with less neurotoxicity, recognizing that it too is generally very well tolerated, but particularly in older patients, just be aware of that cardiovascular risk, which may be more relevant in older patients. Now, in that context, what about continuous lenalidomide? Well, again, I'm not wishing to repeat what Saga covered so well, but the bottom line is obviously lenalidomide is the next step up from thalidomide in this regard, and continuous therapy from the 3-drug platform here has been clearly illustrated from work by Antonio to result in improved outcome, as shown here. And the platform then becomes, how can we, say, replace M&P, one might suggest, with more novel, more innovative, and better tolerated treatment going forward. Now, Saga touched already on the first trial. Again, I don't want to overstress this, but I think the argument that 3 drugs is indeed superseded by 2 drugs here, of course, is intuitive. But the reality here is that M&P is not now our choice going forward. And in the US, it really hasn't been for some time. So we'll move forward quickly here because I don't want to again repeat what Saga went over previously. So what do we have that's new? Well, we've already heard about the antibodies. And I would propose to you that we'll see very exciting data from Eloquent-1, which of course is continuing, or rather has fully enrolled, and we're looking forward to seeing data emerging from that in due course. And at the same, that's the elotuzumab RD platform. But I want to share with you specifically today some of the data from the combination of lenalidomide dexamethasone combined with the new oral bioavailable proteasome inhibitor ixazomib, which is also known as MLN 9708. Now, the preclinical rationale to it is summarized here, as you can see in this model system, actually in studies led by my colleague Dharminder Chauhan, you can see that basically it's impressive in the preclinical models that this drug does appear to be more active in this model system, even compared to bortezomib. And what's also very clear is in the relapsed refractory setting in a series of phase 1 trials that we were able to demonstrate that ixazomib is well tolerated either on a weekly or twice weekly schedule and has promising activity. Now, when you combine it with lenalidomide and dexamethasone, it goes into overdrive. And this is work that we've done in partnership with Shaji being the leading investigator here in these trials. And that this basically combination of MLN9708 combined with lenalidomide and dexamethasone, the so-called RID regimen, has been published. And this is the weekly schedule versus the twice-weekly schedule. What I want to show you here is the waterfall plot that Saga showed for the antibodies earlier, and this is also equally impressive for this combination. As you can see, a very high rate and quality of response from this platform. This is weekly proteasome inhibitor with a 3 weeks on, 1 week off of lenalidomide. The progression-free survival from this study is remarkable. And in that same context, when you look at MRD evaluation, you can see, recognizing that this is a subset of patients, so one has to be cautious with the limited numbers, but you can see really remarkable MRD negativity with this all-oral 3-drug platform. So we're very excited by this data and really do feel that this offers great promise. And this was further exemplified by a presentation from Shaji at ASH, from our data set, showing that indeed, even if you use maintenance with this agent, and this is actually with ixazomib used as a single agent, we see continued improvement of response over time with excellent tolerability. Again, these are small subsets, so one has to be cautious before we overread the implications of this data, but certainly they're informative in that they show that with continued therapy with a proteasome inhibitor once a week, we're seeing encouraging results. And just to show you data to support what I just mentioned about improved tolerability, the yellow bars are the tolerability of ixazomib maintenance over a period of time. The red and sort of slightly buff bars reflect the 3-drug combination. But again, I think it would be fair to say, and speaking as an investigator in this trial and one of the lead enrollers, we found this platform actually very well tolerated in our older, frailer patients. So a very important construct. And these were actually Shaji's conclusions for the RID study presented at ASH in December. As you can see, very high quality of response with 90% of patients achieving PR or better. The VGPR rate was 60%. So when you think of this, it's a step up from what we saw with the first trial with high qualities of complete response. The common adverse events included the cutaneous toxicity, but again, particularly on the weekly schedule, this was very manageable. The GI toxicity similarly proved generally very manageable, and there was a minimal or modest only signal from peripheral neuropathy at around 20%, which is very similar to what we've seen, for example, with other combinations, even including carfilzomib and lenalidomide in this same setting. So in that context, the maintenance effect is quite impressive, and obviously the phase 3 trial of upfront ixazomib combined with lenalidomide and dexamethasone versus lenalidomide and dexamethasone is ongoing. It's pretty close to fully being accrued, actually, and we'll hope that that will provide us with even more information going forward. Recognizing also, importantly, that the other study in relapsed refractory disease is already fully accrued, and actually there's been some very interesting preliminary analysis coming from that, which you may be aware of, that will be presented in more detail later this year, but certainly based upon the press release from Millennium Takeda, shows that it met its primary endpoint of improved PFS. So that being said, I'm going to take a little bit of a leaf out of Saga's book as well here to just propose to you that in our older patients too, our frailer patients, we will see an increasing role for the antibodies. And very importantly, I would argue that elotuzumab will be a very important antibody to consider in the older, frailer patient and should make a meaningful difference. And similarly, the other antibodies that you heard about so nicely from Saga will make that difference too. I'm not going to dwell on this because you've heard about it so nicely from Saga a minute ago, but think about elotuzumab as an immunotherapeutic that partners beautifully with lenalidomide and dexamethasone. That is a clear 3-drug platform that would make sense in older patients. You've already heard about the 1703 data, which Saga and I did together actually as part of a phase 1-2 multi-center effort. And this is just updated data from not only what Saga just showed you, but also from the ASH meeting last year. I simply mentioned briefly this, that the Eloquent-1 trial is one that I think supports and reinforces the idea of 3 versus 2. So I will close now by simply saying that as we think about our older, frailer patients, whilst I completely concur with Sagar that tolerability is everything, as we look to the future with non-genotoxic, targeted biologically derived approaches, I think we must think in terms of an IMiD platform, ideally also a well-tolerated proteasome inhibitor integrated into that mix, and arguably then antibodies added rationally to it. So it will indeed be a 3-drug platform that we may offer increasingly to our older patients. And I'd also bring your attention to something we'll come back to repeatedly, is to understand that in our next wave of therapies, we're going to be driven by not just backbone agents that depend on biology, but taking actually something that Sagar shared with me a while ago, which I think is absolutely correct, is that we're looking at strategies that are going to overdrive the fundamental genetic instability of myeloma and so improve outcome. What's particularly exciting too is immune function. Now, we've already heard a moment ago about ELO being a part of that, DARA and so forth. I'd also bring your attention to the excitement around other drugs that we'll talk about a little bit later that may be very promising and may get their way quickly up into the upfront setting. So my argument would simply be that in the context of less is more, it's very important to recognize that we do need a rational platform for enough. And in our older patients, that's just as important as it is in our younger. And I want to close by simply acknowledging my fantastic group that it's my privilege to be part of, with our laboratory team on the right, clinical team on the left, and of course, my mentor, Dr. Ken Anderson. Thank you very much.